So we're gathered here today to talk about this common format for reporting diagnostic events or diagnostic errors. And so you've got several folks on the line from SIDM, the Society to Improve Diagnosis in Medicine. I'm Sue Strand. I'm the Senior Patient Engagement Advisor for SIDM. Jerry Castro is our Director of Quality Improvement. We have Marie Jaffe. I think we have Tina Huff on as well. So you've got a whole team of SIDM folks. I don't know if Paul Epner, our CEO, is on, but I know he's working hard on this behind the scenes. So I'm just gonna jump right in, kind of why we're here. We're just gonna give a quick background on how we got here, sort of what's missing and why this piece, the step that AHRQ is taking is a big deal. And then Jerry's going to give us a better picture of what exactly this common format is, what the process is, what the form is, and then how to actually submit the comments. It's unfortunately not a super simple process, so that's why we wanted to have the opportunity to kind of talk through. And then I'll close us out by really thinking about how you can leverage the lived experience of patients and families. I will admit I work every day in patient engagement, and it actually took me a little bit of time to read through the format and think about how we best kind of infuse that lived perspective of dealing with diagnostic errors and the diagnostic journey. And then we will talk about next steps and what you can do if you or your organization is interested. So just doing a quick kind of review of why this is such a problem, how much of a problem is diagnostic error. This is a picture of just the definition, and some of this is obvious, some of it may not be. So it's both the need to find an accurate explanation of patient health problems, as well as, explaining that in a way that patients can actually understand it. Communicating is an integral piece of appropriate, accurate diagnosis. And it also needs to be timely. So delays in diagnosis can be just as problematic as having the wrong diagnosis at all. So it's really all three of these pieces, and you're going to see this kind of definition show up again when Jerry talks about what exactly the common format is designed to sort of tackle. And here's just some facts and figures that, again, you may be familiar with. This is not just a thing that happens to other people. This happens all over the place, unfortunately. They're not always serious. Some diagnostic errors aren't particularly harmful, but the concern is, why did it happen in the first place? And what if it is harmful next time it happens? And so we see all of these facts and figures. We know that the National Academy of Medicine estimates that all of us will experience at least one diagnostic error in our lifetime. Again, maybe not a serious one, but it's happening at that rate of frequency. So we know they're the most common, most harmful, and most costly of all diagnostic errors. And so having that as background, it might be sort of shocking to see that there's really no national common framework for diagnostic safety event reporting. There's no systematic way that everyone has agreed upon to communicate about this and talk about it for shared learning. So that's what this process is sort of embarking upon. There have been some efforts through patient safety organizations or PSOs, but nothing uniform like what is underway right now. And the reason this is important, and again, some of these are probably obvious, but it helps to just think very concretely about it. First of all, it's just a lost opportunity to learn and to correct behavior. And any of you who have experienced diagnostic error, I have personally, that was one of the most troubling things, was that I had gone through all of this. There had been really grave errors, and then it seemed to sort of evaporate into thin air. And I know it is likely going to happen to someone else down the road. And that is such a lost opportunity. And that doesn't just exist at the individual level, it exists at the system level. So the same error could be perpetuated across multiple systems affecting multiple people if we aren't able to learn from and correct behavior, correct processes, correct practices. Certainly those bad experiences can harm the patient-clinician relationship. And we hear from patients all the time that going through that really changes your trust and how you interact with healthcare. So this is another way that this can have such such negative ramifications if we don't catch it and figure out how to learn from it. And then the bottom line is, this is just one way to keep patients and families safe. And it's sort of a head scratcher that we haven't been doing this already, but this more systematic, formulaic way to describe error and really document them, we hope will lead us down a better path. So at this point, I'm going to hand it over to Jerry Castro, our Director of Quality Improvement, to talk more specifically about what this all means and how this process will work.
All right, thanks for that introduction, Suze, and nice to meet you if I've not met you already, and glad to have you back if I have. So the AHRQ common formats for event reporting are what we call a standardized definition. They represent standardized definitions and categorizations to collect data on patient safety events. So if you think about those things that go wrong in healthcare, this is just a common way of organizing the information around patient safety events. It's not a reporting system. So when you go to the hospital, there might be a complaint reporting system. You know, if something goes wrong as patients, we have the ability to let organizations know about it. So it's not a reporting system per se. It's just a way of organizing the information within that system. So organizations and healthcare providers use the common formats to report patient safety events, or as a framework to report patient safety events. These common formats are available in the public domain, so anybody can download them, and there are event-specific modules for hospitals and nursing homes. And there, the link for the overview of the common formats is located on the left-hand corner if you're interested. Next slide, please. So this slide represents at a high level the commenting and development process for the common formats. And so the commenting process starts with NQF. So NQF, or the National Quality Forum, collects comments on a draft common format. Well, I should say there's actually a preceding step in which AHRQ actually releases the draft common formats and using NQF to facilitate this process. So once NQF receives these comments, an expert panel considers and reviews these comments and develops recommendations around them and submits them to AHRQ. AHRQ will then consider those recommendations and then issue the actual draft of the common, or the real common format, the common format itself. Next slide, please. So the common formats for event reporting for diagnostic safety are composed of 3 different documents. So there's the guide, the event description, and then the form. So if you're going to review the common formats, definitely start with the guide, because what it does is it provides concepts and definitions and the framework for going through the common format itself, or what they're proposing. The event descriptions are just a listing of the different data elements, and then the form itself looks like a reporting form, but it is the way that they have organized the data elements to capture the specific information, or the proposed way of capturing information. Next slide, please. So in the guide, they define a diagnostic safety event as one or both of the following: whether or not patient harm has occurred. So the first one is delayed, wrong, or misdiagnosis. So they define that as there were one or more missed opportunities to pursue or identify an accurate and timely diagnosis. So you'll remember that Suze went over the National Academy of Medicine definition. It was composed of, it contained those 2 elements, accurate and timely. So accurate and timely diagnosis or other explanation of the patient's health problem based on the information that existed at the time. The second component of this definition is the diagnosis was not communicated to the patient. So again, an accurate diagnosis or other explanation of the patient's health problem was available, but it was not communicated to the patient, which includes the patient's representative or family as applicable. So when I first reviewed the common formats, like Sue said, it took me a while. You know, I've been working in patient safety almost all of my career. And when I was reviewing the common formats, it reminded me of a traditional root cause analysis. So if you think about, you know, our own events, or what has affected our own family members. An organization does an analysis on how that event transpired, right? So if you look on the left-hand side, we talk about, well, what actually happened? You know, it was a missed diagnosis. It was a delayed diagnosis. And then we look, when we do the analysis, we look to see how that event transpired. What actually led to that final consequence, or that impact on the patient, how we were harmed, and the preceding events, and ultimately what were the initial conditions. So if you think about this, this is the who, what, where, when, and why, right? And ultimately, when we do this type of analysis, what we want to try and uncover are the why factors, and those are on the right-hand side. So for the sequence of events, what we're trying to do in our analysis is determine why this particular event happened. And then you'll see here, delineated by the organizational factors, or what they call organizational factors or organizational weaknesses. And so once we identify those things, what we try and do is develop an action plan to reduce these things from happening again. We've identified that maybe there was a missed test result. You know, what were the factors that led to that missed test result? Or, you know, there was maybe perhaps cognitive bias associated with the case, or the, you know, clinicians did not communicate with each other. Those are factors which we want to characterize, uncover and characterize. And so ultimately, that's what we're trying to do with the common format for diagnostic safety event reporting. So next slide, please. So what I've done is, at a high level, I've taken the concepts and definitions contained within the common format and organized them using that patient safety event analysis framework, or that root cause analysis framework. So in the guide, they talk about an event trajectory, like how this actual event transpired. So it starts with the first diagnostic episode at the top, and then it ends with a final diagnostic episode where an accurate diagnosis is identified, okay? So in the common formats, they go through great lengths at describing, you know, these different concepts. And so what I've done here is diagrammatically outline them for you. The dark blue shaded boxes indicate specific forms, or, you know, the sections of the common formats that they're asking organizations to fill out. So from the first diagnostic episode to the final diagnostic episode, there are a number of what they call diagnostic episodes, all right? So if you can think about this, the first diagnostic episode is when we first go to, for example, our family practitioner, right? And they refer you to a specialist. So the specialist will refer you to a test. That is a diagnostic episode. If that test result is missed, maybe that's what they call a diagnostic episode with missed opportunities. And then so if you look at that box off to the right, what they're going to ask you to do with the common formats is collect certain elements of data around the certainty of that diagnosis, what was the setting that diagnosis was made or the diagnostic episode occurred in, what was the actual documented diagnosis at that time. Was there actual information that could have led to an accurate diagnosis? And then they talk about the specific type of diagnostic process that was involved, and then specific potential contributing factors. When characterizing the final diagnostic episode, they want to find out information about when was that accurate, or what was that accurate final diagnosis? When was I identified? So they want to track the time between the first diagnostic episode and the final, right? So that speaks to the timeliness of the diagnosis. Whether or not it was in fact communicated to the patient, right? So again, that's another one of our criteria for diagnostic safety event. What was the setting where the final diagnosis was made? And then what ultimately led to discovery or recognition, right? Maybe it was the patient that insisted, well, I think it's this diagnosis, right? So those are different kinds of data elements that we capture there. We also want to capture impact on the patient. And so I think there are different, in this, I'll go into this in a little bit more detail in a moment, but I think this is where there are different components of where you as a patient and family facing organizations can help us create more detail around the common formats itself. Finally, there are forms on patient, or there's a section on patient and reporter data, and then there's a brief narrative, which is optional to describe the event as a whole. So let's go to the next slide, please. So this is a screenshot of the actual form, and this section talks about the impact of the diagnostic safety event on the patient. So as you can see here, item number 3.1 talks about the impact on the patient's condition. So there are different, this is what we call in, in technical jargon, a harm scale. So it can be no harm up to death as the consequence as far as an impact to the patient. And then there's an added consequence here, probable impact, severity, unquantifiable. Now I will say with regards to the harm scale here, this is consistent with the other common formats for hospital reporting. So this particular item is not necessarily unique. But they do talk about an impact on the patient's condition, functional ability, quality of life, and whether or not it requires other intervention. And then it goes from none, mild, moderate, severe, and then ultimately death. Item number 3.2 talks about the duration of the impact. So they characterize it as either permanent harm or temporary harm, not expected to have a permanent impact, or unknown. And then item 3.3 talks about, what was the effect on the patient and family, right? So there's additional anxiety, emotional, psychological distress, additional financial costs and time, and then other impacts on career, and then other impacts as a whole. So that is actually different from the basic hospital reporting. And so that is a specific addition for diagnostic safety events, which I would argue should be for all reporting as a whole. Next slide, please. So this one talks about what prompted discovery of the accurate final diagnosis, okay? So you'll see here, there are certain things: patient's original symptoms did not resolve, deterioration of the symptoms, fresh eyes, and then, but what I want to point you to is item G, patient initiated, right? So how did the patient, and then if you answer that, if you select that, they suggest collecting information on how did the patient initiate discovery of the accurate final diagnosis. Patient called provider's attention to new or unseen clinical data. Patient called provider's attention to existing clinical data. So we've heard that a lot from patients. And then patient insisting on pursuing another diagnosis. So, helping us clarify what are the other ways that we can bring this, patients can initiate this discovery of an accurate final diagnosis would be helpful too for us. Next slide, please. And the other data element that I wanted to just bring up for discussion is this element here, which characterizes the how or who participated in contributing information to answer the questions around this analysis. And so you can see the list here, the clinician who identified the final diagnosis, and supervisors, clinicians, patient safety and quality improvement professionals, risk manager. But I just went through a list of how patients can initiate this, and they're not listed here as contributing to the analysis. So that's a definite shortcoming as far as what we've seen. And this is again our initial analysis of the common formats, but having an explicit mention of the patient being involved in the analysis, we think is an important component of this that is clearly missing right now. So let me stop there. I know this tends to get a little bit technical in nature, but let me see if there are any questions, if I could clarify anything about what I just covered here.
Any questions for Jerry? And I can't see the chat function in the orientation of my screen. So Marie or Jerry,
Okay. There's nothing there.
Okay. Okay. Great.
This is Jennifer Dexter at National Health Council.
Oh, great. Hi, Jennifer.
Hi, how are you? Just curious. I think I really appreciate your emphasis on the patient involvement and the engagement. I just wondered if there is, I have not looked at it yet, anything in here in terms of looking at equity and tracking demographics of the patient and where these events are happening.
That is an excellent point, and that is currently a shortcoming of the common formats right now. The data on the different socioeconomic data or even race or ethnicity data is not currently captured in the common formats.
That's a great question, and Jerry, I don't want to creep into your lane because you're the expert in this field, but just to follow up on that question, that's despite the fact that we know there are significant racial and ethnic disparities in diagnostic quality. SIDM just is wrapping up a project in that space. So definitely a really key category to look at.
Excellent. Thank you for that.
Hey, Suze, it's Gwen. So for the group, green shirt. So a lot to absorb here. So I'm a patient living with a relatively rare cardiac condition. And it is many, many times in the patients that I represent collectively, years of being misdiagnosed. So I'm curious in this format, which I'm new to, how does it capture a misdiagnosis or a delayed diagnosis due to provider lack of either understanding or education? In other words, it isn't a blatant error as if a test was missed or it was simply putting all the tests or the information together. The clinician simply did not understand the condition well enough to make an accurate diagnosis.
Yeah, and I think that is, that would still be considered a missed opportunity. And of course, this is one of the things that I've been trying to figure out with my colleagues, who is going to actually make this assessment, right? Especially, if we use a just culture model, we would use what we call the substitution test, right? So or in legal terms, it would also be called the reasonable person standard. So if another clinician of the same level, if we're talking about residents, for example, if another resident were in the same position with the same amount of information, would they make the same determination? And so, if the answer is yes, then unfortunately that just speaks to the level of expertise or the knowledge as a whole. But however, if they, quite frankly, I hate to say it, if they should have known better, then that is definitely a missed opportunity. But you could also, and again, this is something that we're going to have to tease out, which I'm not quite sure about, and this is a nuance. Could we say that there was a missed opportunity to access specialty care? And I don't know. And, actually you bringing up this example, brings another nuance to this whole activity that I haven't even thought about. So that I think that's something I'm going to have to think about a little bit more.
Yeah, Jerry, let me also jump in. Gwen, nice to meet you. I'm Paul Epner. I'm with CITM as well. So, you know, again, as Jerry pointed out, it's this missed opportunity. But if you look at someone like, there's a guy named Bill Gall who runs the undiagnosed problems through NIH. These are sometimes it's the disease of one in the world. They're unique. Clearly, no one could know everything there is to know. That would not be considered an error if it takes years to find something that doesn't exist anywhere else in the world. But I think the key would be if you have a final diagnosis, and you said they've been going for years in your example and not getting the diagnosis. When that diagnosis occurs, now you do that look back. What did that final diagnostician do that got to the right diagnosis, and what was the trigger for doing it? And when was that trigger first present? So was it an unexplained weight loss? And the first doctor was too patient, maybe for 6 months, 12 months, while someone was kept losing weight, and just, they said, you know what, you're just under a lot of stress. And then a year later, someone does a colonoscopy, finds out they have colon cancer or something. So again, that first physician may have missed a clue, may have failed to appreciate a clinical finding and act on it. That is a delay. That is a diagnostic error that a physician should be able to figure that out, or at least know that they need help. A specialist, as Jerry said, a second opinion, even among their peers. So it's usually in retrospect, when you're the situation you described, when they get to that right diagnosis, and then doing that analysis of the process that got us there. Does that make sense?
Yes, it does, and definitely understandable. So trained as a cardiothoracic PA, so certainly I understand the clinical. I think in this case, and it may be true in others, there is over time an advancement and an understanding of a medical condition that simply wasn't available to even the best clinicians or the best of the best 10 years ago. And so, you know, I don't want to simplify it as saying it's more medical education or a physician continuing education, but I think in some of these situations, or at least the one I'm most familiar with, over time, there's been a broader understanding among cardiologists of this condition. It's now taught or explained in residency programs. So that's corrected for it. But yet there's still a population of individuals, myself being one of them, that were misdiagnosed or sent off on various paths, you know, decades ago, that have resulted in complications now. So it's not everyone, but I'm sure there's situations where the sheer lack of scientific knowledge has created a missed opportunity that over time has sort of course corrected.
Yeah, so in that case, if there was a lack of knowledge, there wasn't a missed opportunity. In retrospect, and I see a couple hands up, so I better stop talking, but let me just say that the Supreme Court took on the issue of pornography quite a few years ago, and someone asked for a definition, and the Supreme Court justice said, I can't define it, but I know it when I see it. And so I think the same is true with delays in diagnosis often, is that in retrospect, you can say this was unnecessary. There was a missed opportunity.
I think, Gwen, the point you raised, though, I think is exactly why it's great to have you all on this call, and why it will be so beneficial if you and your organizations can contribute to what the response will be, because I think all of those nuances to how our different disease states work, how our diagnostic processes work, we're all pretty different across the sort of the broad disease and disability community. And so I think we want to raise those things. What my, you know, I would hate to see a lot of work go into a common format that gives short shrift or inadvertently makes it more difficult to communicate for certain diseases, but works well for other diseases. So I think this rich context that you're raising is really key. Any other questions before I move on? I'm gonna take us into the next part, which is really a continuation of what's just started, which is orienting.
Suze, you have 2 hands raised. I
Oh,
see
great.
David
Okay.
and Kat. Yeah, you may not be able to see
Okay.
them.
I'm not sure who had their hand up first. If we go in alphabetical order, I'll start with Kat and then go to you, David.
Okay. Hi, everybody. This is so helpful. Thank you. And forgive me, I don't know as much as I wish I did about this process. Can you help me understand? You're saying AHRQ came up with this and then we're all commenting on it. You guys are. And who can report? I mean, I could imagine, I would be so freaking excited if all the familial hypercholesterolemia patients in the country could report their missed diagnosis. And then my final question, but I have a feeling that's not going to be possible. But anyway, that's my question. Who reports? Who's using this form? And then finally, is this, you know, a quality, is this what happens? Is this like a star rating, or what happens with the information, and how does it drive change and improvement? And then my final, just one of the things I would add is on one of the previous slides, that I think a lot of health systems are having these quality improvement efforts at using maybe big data or searching their EHR using predictive analytics. And that might be hopefully one way that people are found to have their diagnosis. So that would be a category we would suggest they add to that previous list.
Yeah, thanks for those questions, Kat. And so to your first question, who can report? That will depend on the organization itself. So some organizations do a great job of soliciting patient feedback on their diagnosis. So it could be a patient-based reporting system. They could use open notes, for example, you know, patients' comments on their clinical notes to gather information on potential safety events. And, you know, but as a whole, I'd say healthcare does not do a great job of doing that right now. And so we're still kind of at the beginning of that kind of activity. But go ahead.
I'm even a little more fundamental. You say organization, like what organization?
I'm sorry, hospitals and healthcare
This
systems.
is all hospital reporting?
Right, yeah, so this is the AHRQ common format for hospital event reporting, right?
Okay.
Sorry about that. But yes, so a hospital or healthcare organization can use the AHRQ common format as a framework for looking at these safety events. However, they need a mechanism for collecting them. And to your point about big data, they might actually be looking at, you know, their utilizing big data techniques, analyzing medical records for diagnostic safety events, you know, using, you know, artificial intelligence techniques and pulling that information using some sort of trigger is what they call them. As far as, you know, what are they going to use this data for? It's to identify where in their organization are there problems. You know, specifically, you know, they track the setting of the particular safety event. So maybe it's in the ED, maybe it's ambulatory. And so what it allows an organization to do is do a better job of looking within that organization, you know, where the problems are, and to characterize those problems so that they can leverage improvement resources, you know, develop some sort of quality improvement project around closing the loop around test results, for example. You know, if they identify that as a problem from safety event reporting, they can start to say, okay, well, this, you know, here you go, hospital CEO, this is why we should be focusing on this, or this is why we should be doing a better job of getting, you know, patients' feedback on these types of events.
And to the question about who can report, Kat, this is something near and dear to my heart. So this sort of our, in my opinion, the best we can hope for this work is that we strengthen, and on the next slide, I have some ideas about how we strengthen even the format to compel more direct report from patients, that patients and families are looked to as a data source. I think the next sort of the holy grail where we want to go in the future as a system is a whole reporting system that patients themselves access. I look at that as sort of the, that's what I hope for on the horizon. So I'm sort of you know, to tide us over until we can get there. What would be great is if this format actually promoted more robust, direct data capture from patients and families. So I'll talk about a little bit on the next slide, but David, I know you had a question too.
Yeah, I'm sorry, I missed a good portion of this presentation, and if my question is out of line, just tell me that and we'll go on and do whatever. But I'm curious to know whether anything in the reporting format, because I haven't looked at it yet, addresses patients who are referred for psychiatric or psychological evaluation who go on to turn out to have chronic fatigue syndrome or lupus or any of a zillion conditions that cause depression and other psychological symptoms. Does the common format have a way to count that as contributing to the error or the erroneous diagnosis of a psychological condition fit into this corrective process in any way?
Yeah, so there is actually a component where they characterize the impact on the patient's condition, where it not only includes the medical condition, but also includes the psychiatric condition, even if it's temporary. So and that's actually I think I mentioned also they talk about quality of life. So as you know, as a potential impact. The problem is it's not like you can give it a score. It's kind of tough to say, you know, well, this out of a scale of 1 to 10, this is a 7, right? So I'd say that's one of the limitations, but they do account for that in the form itself.
Okay, thank you.
Mm-hmm.
Suze, I also have one question. This is Dan Berg.
Hey, Dan,
I think this is short. Hi. So does the use of the common form, is it triggered by one of two things? Achieving a correct diagnosis or the death of the patient?
So actually, it will be triggered by the identification of a diagnostic episode with a missed opportunity, right?
Yeah.
And so it would not, it doesn't, even if there's limited impact on the patient. Oh, go ahead.
We have milk.
Oh,
And
I think someone needs to be muted.
Yeah, can you mute?
Got it. I got it.
Okay.
Sorry. So yes, it is intended to be even for to utilized on what we would call even a near miss or close call, right? So if there was no impact on the patients, but they recognize, oh wow, we missed this, and so absolutely.
But the loop has to be closed.
That's
with
correct.
Correct diagnosis.
As it stands today, it has to be closed with a correct diagnosis, and that's actually a great point. One that somebody else had brought up in the context of our discussions, that can this be used on a diagnosis that has not yet been accurately identified at the end, right? Yeah. Yeah,
which is a clear shortcoming because, you know, we know I would look at that almost as an open case. It's still still being debated.
One of the other things that I think all of our patient-facing groups should consider, from the old expression about ignorance is bliss, the health system is asking questions that it thinks it needs the answers for. One of the things I think the patient-facing organizations can bring is the perspective of, you're not asking the right question, so you don't have the blanks for the information. The question you should be asking is, you know, when it comes from the patient perspective. So each of the patient-facing organizations could think about the diagnostic errors that their constituents experience and think about what question needs to be asked and answered in order to improve that process for that group of patients, and then look back and say, it's missing, or is it missing in this process.
Yeah, I think that's right. And actually, Paul, that leads us right into this slide, which is really kind of trying to hone in on what is our role as patients and patient-facing organizations. I'm going to start at the bottom of the slide because that's what we've been talking about so far. Really thinking about the process. When I read through the format, it doesn't seem to compel questions and sort of the invitation directly to patients and families. And I think that's a miss. I think we want it to sort of scream to whomever's using it, hey, talk to the patients and families. They are the single longitudinal source of data across the entire episode. The only source of data that can be from point A to point B. Everyone else comes and goes in that diagnostic episode, but the patient or family is there throughout. And then along those same lines, and this is something we're kind of thinking about in the open notes world, is what if there's a difference of opinion about how that all played out? And is there something in the format that, how do we weigh the information? What if the way the patient says it happened is not what the hospital says happened? And how would we address that? And there are probably 20 other process questions you can all think of, some of which you've sort of raised. Then if I go up to the top of this list, some of the more kind of technical things, just looking at these questions. If they did a good job of inviting the patient and family in to provide data, do these questions make sense? Are they answerable? To Paul's point just now, is it the right question? So that second point, do these even cover all the important pieces of the diagnostic process? Are the answer choices relevant and important? And in most cases, there's an other. But what I wonder is, are there some others that we think are going to show up quite a bit, such that they should have their own answer choice? Is there any language that's blaming, or are there tonal issues that are worrisome as you read through this? And are just any aspects of capturing that diagnostic error missing? When you think about, as Paul said, what your constituencies face, to Gwen's point earlier, if it takes years across multiple clinicians, or is it a sudden event where people tend to get diagnosed immediately if they're getting diagnosed accurately? How different do those scenarios play out? And does the format work across those, or do there need to be adjustments to make it more suitable, more appropriate? Just as we were talking about this sort of as a team a couple days ago, we started thinking through, specific parts that may or may not need to be adjusted based on experiences we've had or that we know about. And so this is just a quick snapshot of a couple of examples. This is someone on our own team that had a very delayed, dangerous diagnosis of appendicitis when it was very late in the process, despite a full diagnostic workup. And her question was, but the way I read this format, it looks like it's sort of one clinician that is involved. How would this apply to every single clinician that I got bounced around to until I got the right diagnosis? Do you fill out a report for each clinician? How does it work when it's sort of that frantic figuring out of what went wrong and what was missed? In my world, in rheumatologic diseases, I guess you could get there, but on question 3, when it talks about impact to the patient, I didn't feel like the answer choices actually were a good hit for our disease states, because there's sort of this second half of the sentence that talks about, does it change the treatment trajectory? And well, that's not really the issue. The treatment is kind of the same because the treatment is what it is. The difference is if you are diagnosed late, you have really poor outcomes compared to people who are diagnosed early. It's all of the permanent damage that results. It doesn't have as much of a bearing on the treatment. And I feel like that gets a little bit lost just in the way it's worded. And then we have a different example, again, in a setting where things are frantic. Maybe the diagnostic error started in an ambulatory setting, then was continued in a surgical center, went to the patient's home, came back for an inpatient stay. How does one format cover multiple sites of care, multiple providers? So all of these things that we all know better than anyone because we've lived them, we've experienced them. How do we build this format out to best capture that data and make sure it really ends up providing usable data that we can learn from and keep patients and families safe with? So the actual process then, and I'll go through this pretty quickly because there's this gets super detailed, and Jerry actually produced a great video that we'll share that walks you through each type. But so the format is complicated, and so is the process to submit comments. So your first option is if you wanted as an organization to submit your own comments, you would go to the landing page. This is the link on the slide at the NQF. And you actually, so I've circled where you go. So you go to that page. It's going to ask you to either create an account or log in. And then you actually go through sort of step by step, and it gives you, Jerry, I think, free text boxes at each section, and you enter the data you want to enter. So there's not the typical sort of public comment option where you draft a letter on letterhead and submit it. So that's option one. And we will, as I mentioned, circulate a video that Jerry developed that just kind of walks you through how to access that system, what it looks like. But even though there's not a formal letter submission process, we're going to draft our technical pieces, but we're also going to do an accompanying letter. And that's what we can offer as a sign-on option. We know this is a lot to tackle. There's a lot to read through, a lot to get through, but you've all already raised so many important issues that we would love to include. So Tina Huff has developed just a simple online form that will allow you to access our letter once we have it done. You'll be able to sign on through that little online form. And then if you have substantive comments, if you have categories that you think are missing, language that's problematic, just contextual factors that concern you that you really want them to take into consideration, or to your, I think, Kat, you asked about, what about getting patient report? How do we move down the road to get patients reporting this activity? I think all of that is fair game for those substantive comments. And then we can compile all of that and submit it as sort of an appendix to our letter that will accompany our technical comments. In order to make the deadline, we just ask that you complete that sign-on by June 29th. And we'll get our letter to you hopefully, Jerry, I think end of this week, maybe, or we're working on it night and day, trying to work through our comments and determine all the things that we want to speak to. So that's the two sort of options for submitting comments. And then I just want to kind of close with, this is really the first step. I mean, you've heard this is really exciting, but it's definitely a first step. We have several steps to go after this stage. So we are excited to have you here on this call, but we think this is the start of something more long-term, and we'd love to keep talking to you. You truly have that unique perspective that no one else in the diagnostic setting can provide. And so look forward to just partnering with you and your organizations as we kind of work to tackle this and really get it figured out. So let me pause there and see if there are any other questions, either technical questions about how option 1 or option 2 works, or more of the substantive conversation that was happening earlier. And Marie and Jerry, I defer to you because I can't see chat, but I think
it's empty.
Okay. There was so much great discussion already. I think a lot of really important points came up.
But it's Kat here. I just want to thank you so much for the work that you're doing and for calling our attention to this, because I could see it as being really powerful to sort of push for change and improvement, where diagnosis, there are some diagnoses, as you've said, of course, that are really challenging, but there are others that are just not that hard, and there needs to be an incentive to get it right and move on and spend your time on the harder diagnoses. So I'm really excited about what this might mean, and hopefully it'll get incorporated, and then maybe I think we'd be very interested in brainstorming ways to make more of it. Like we're working with health systems. I don't know if it's unreasonable to think that patients might go in and say, hey, I'm seen by a doctor at the University of Pennsylvania. Hey, doctor so-and-so, now that you've diagnosed me, could we fill out this form you may not be aware of?
Yeah, that's great. That would be wonderful. Yeah.
I think it could be really interesting.
Yeah.
Satisfying for patients.
Yes. it closes a different kind of loop, and that's important. It closes the knowledge loop. Yeah.
Well, it makes them feel like somebody, it's so frustrating along the way. And I think I said this in my email. I'm sure you all have this experience, right? Usually people they say, oh, I fired my cardiologist because they didn't know what they didn't give me the right information. But when they say they fired their cardiologist, they just moved on. They didn't say anything. They didn't tell anybody that the cardiologist didn't get the information that they missed a diagnosis. And so I think it's incredibly powerful because nobody wants to be that person.
Yeah.
Anyway, thank you is what it all boils down to.
Thank you. No, thank you. We're honored to be able to work on this. So hopefully we can make some changes.
Yeah, this is Chad with Ovarian Cancer Research Alliance. I really appreciate going through this. I'm really excited to see Jerry's video. I think that'll be a highly rated viewing here in the household. But I want to, I'm looking forward to going through this in a little bit more detail. I think my community is a historically difficult disease to diagnose, and so it's I have a very excited community that would be willing to participate in any reporting of diagnostic errors and delays. So, however we can make this as easy as possible for patients to contribute and participate in this, it will be great. It's a little bit, going through the language, it's a little bit difficult to see patients being able to participate in this reporting. It almost takes like an omnipresent healthcare presence to look at the whole journey as it stands. And I'm wondering if there's a way for it to be simpler, at least for patients on a portion of this to participate in reporting. And also, waiting until you have a confirmed final diagnosis is also going to be tricky, I think, for a lot of patients in the healthcare systems, particularly with difficult to diagnose diseases. So I think that there's a lot of room to improve, but this is a great step forward, and we'll be happy to participate in trying to improve this and making it better.
Can I add one point, Suze, that because Chad, I didn't know, I don't know if you also include, I'm sure you still also include the maybe the HBOC, the hereditary cancers. And one of the points that we would certainly add is that there's also a missed opportunity, not only for that individual patient, but when you have hereditary conditions, if you're not those two steps, properly diagnosing that it's a genetic driver of whatever, ovarian cancer or heart disease. Cardiomyopathy is a great example also, right? And two, that you haven't communicated the diagnosis in a way that means that the rest of the family will get the information that they need. I think I didn't see that captured yet. And so that would be part of what we would, is it for hereditary conditions? It goes beyond the patient, the missed opportunity.
Right. That's so important. And
yes, it's Gwen. I wanted to just something is coming to mind here. How do you handle a complex diagnosis where within an umbrella, I'm kind of envisioning of a large complex chronic illness, there are multiple diagnostic points along the way. So whereas the patient might have the overarching accurate diagnosis, but there's some component of that, there's a hypertension component. Someone mentioned there's maybe the interplay with depression there, so when I'm thinking about this, is it the overarching, major diagnosis, or is it the same person could have an accurate overarching diagnosis, but have subcomponents or some aspects of it that were delayed or missed? Does that make sense?
I think it does. Jerry or Paul, I might defer to you because I'm not sure how the common format in its current version would address that. I don't know whether there is almost like it rolls up into a single episode, or whether you would treat each sort of unique diagnosis as its own. I don't know how that would work.
Yeah, as I understand it today, you would be tracking a singular diagnosis because it's tied to the final diagnosis at this point. And I'm kind of looking through the format right now to see if there are any other things. I don't see it right now, but I could be wrong. But yeah, right now it's just tied to the final diagnosis at this point.
Great question. Great questions, all of you. This has been fantastic. I'm going to put our emails up here. I think you've already heard from one or both of us already, but now you've got them here, and we'll send the video. We'll make this recording available. We'll make our comment letter available when it is finished, and that will come with this online just form to complete. But thank you all. I've taken notes just from what you've already said. I think there's a lot of agreement on some of the big things we want to focus, but then each of you have raised really fantastic, unique things that are specific to your disease populations that I think will be really key for you to capture. So if there's no further questions, thank you all so much. This was great to be with all of you. Enjoy the rest of your day, and you'll be hearing from us soon.